Now that you have the fundamentals of both ocular history taking and examination techniques, we will shift our focus for the next part of the video to reviewing a selection of important abnormal exam findings. The final section of this video is meant to help organize your description of the eye exam and to formulate a differential diagnosis with respect to abnormal findings. We will start with the visual system and proceed to pupillary disorders, ocular motility disorders, gaze palsies and nystagmus, and end with optic nerve disorders. Confrontational visual fields is a quick and easy method of assessing a basic visual field at the bedside without requiring any special equipment. Remember to always test each eye separately when evaluating visual fields. Any suspected visual field defects should also be followed up with further formal visual field testing performed by an ophthalmologist in clinic, for example, Goldman or Humphrey parametric testing. Certain patterns in visual field defects can be mapped to specific locations within the visual pathway, as shown above. Remember, in a basic sense, the visual pathway begins with the retina, whose axons form the optic nerves. There is a partial crossing of these axons at the optic chiasm, which then becomes the optic tract. These fibers synapse at the lateral geniculate nucleus, from which the LGN axons fan out as the parietal and temporal optic radiations, which extend to the primary visual cortex in the occipital lobe. For example, a complete unilateral visual field defect is associated with a lesion of the ipsilateral optic nerve anterior to the optic chiasm. A bitemporal hemianopsia, meaning a visual field defect in the temporal region of each eye, is associated with a chiasmal lesion. A pie-in-the-sky visual field defect, or superior homonymous quadrantinopsia, meaning both eyes on the same side of the visual field, is caused by a lesion in the contralateral temporal lobe involving the Meyer's loop of the optic radiation. A pie-in-the-ground visual field defect, or inferior homonymous quadrantinopsia, meaning both eyes on the same side of the visual field, is caused by a lesion in the contralateral parietal lobe involving the optic radiations. A homonymous hemianopsia with central or macular sparing is caused by a contralateral posterior visual cortex lesion. You may always refer back to this diagram for review of specific visual field defects and their associated lesions. Over the next several slides, we will review the pupillary light reflex, discuss testing and relevant abnormal findings. Let's review the pupillary reflex, which involves two pathways, an afferent and efferent pathway. The afferent limb begins in the retina. Light stimulates photoreceptors in the retina, and the signal is conveyed to a special set of ganglion cells that send their nerve impulses through axons in a similar topographic distribution as those carrying other signals in the optic nerve. The pupil fibers, along with the visual fibers, decussate in the optic chiasm. The nasal pupillary fibers cross in the chiasm to the opposite optic tract, but do not synapse at the lateral geniculate body. The papillary fibers synapse on the pretectal olivary nuclei of the midbrain, which then project bilaterally to the Edinger-Westphal nuclei in the third nerve nuclear complex. The efferent limb can be divided into two pathways, the parasympathetic and sympathetic. The parasympathetic pathway begins at the Edinger-Westphal nuclei, which send fibers to the dorsomedial aspect of cranial nerve 3, passes through the cavernous sinus, and enters the orbit with the inferior oblique branch of cranial nerve 3. These fibers synapse at the ciliary ganglion and then continue in the short posterior ciliary nerve to the iris sphincter. The parasympathetic pathway constricts the pupil. The sympathetic pathway begins in the hypothalamus and travels down the spinal cord to the C8 to T1 level. The descending sympathetic fibers activate preganglionic sympathetic neurons in the intermediolateral cell column of the upper thoracic cord. From there, the fibers exit the spinal cord, passing over the apex of the lung to the superior cervical ganglion. The fibers then enter the skull base with the internal carotid artery and enter the orbit, traveling towards the eye to allow the pupil to dilate. Evaluation of the pupillary response to light stimulus tests for an intact pupillary reflex. The normal response of the pupil is to constrict in light, and in fact, this response is consensual, meaning that shining a light in one eye should result in pupillary constriction in both eyes. Presence of a relative afferent pupillary defect, or Marcus gun pupil, indicates damage to the pupillary reaction pathway, specifically the optic nerve. To evaluate for an RAPD, the swinging flashlight test is used. If an RAPD is present, upon shifting the light from one eye to the other, the pupil will respond with a paradoxical dilation, as demonstrated in this patient who has a right RAPD. Here we show both an animated example and a true example of the paradoxical dilation to direct light of the pupil on the affected side. Anisocoria is characterized by an unequal size of the pupils. Anisocoria is relatively common and can be found in approximately 20% of the normal population. The most common cause of anisocoria is physiologic, with pupillary size discrepancy of 1 millimeter or less. Other causes of anisocoria include pharmacologic dilation, cranial nerve 3 palsy, 80s tonic pupil, iris trauma, and Horner syndrome. Remember that anisocoria does not indicate a problem with the anterior visual pathway, meaning the optic nerve. This flowchart demonstrates a basic stepwise evaluation of anisocoria used to search for the underlying etiology. Relative differences in anisocoria in light versus dark conditions, speed of pupillary response, other physical exam findings, and response to various pharmacologic agents are helpful in revealing the cause of an anisocoria. Now we will review extraocular muscles, normal ocular motility, and oculomotor and gaze palsies. Here we will review the 6 extraocular muscles and their corresponding eye movements. The primary function of the medial rectus is adduction, which moves the eye inward towards the nose. The primary function of the lateral rectus is abduction, which moves the eye outward, away from the nose. The primary function of the superior rectus is elevation. The primary function of the inferior rectus is depression. The superior oblique has 3 important functions with respect to eye movements. The primary function is intorsion, meaning nasal rotary movement of the eye. The secondary function is depression. The tertiary function is abduction. The inferior oblique also has 3 important functions. Its primary function is extorsion, temporal rotary movement of the eye. The secondary function is elevation, and the tertiary function is abduction. This diagram depicts the primary extraocular muscles responsible for normal motility in each position. Each extraocular muscle is innervated by a specific cranial nerve. The medial rectus is innervated by cranial nerve 3. The lateral rectus is innervated by cranial nerve 6. The superior rectus is innervated by cranial nerve 3. The inferior rectus is innervated by cranial nerve 3 as well. The superior oblique is innervated by cranial nerve 4, and the inferior oblique is innervated by cranial nerve 3. This animation demonstrates full and normal extraocular muscle motility. The patient is looking at the target just as you would have your patient follow your finger or other object. The third cranial nerve. The nucleus is located in the midbrain at the level of superior colliculus. It directly innervates the ipsilateral medial rectus, inferior rectus, inferior oblique, and the pupillary dilator muscle. It also innervates the levator aponeurosis via a central nucleus, which controls the upper eyelid, and also indirectly innervates the contralateral superior rectus. Therefore, a cranial nerve 3 lesion produces lid ptosis, dilated pupil, and downward and a lateral deviation of eye position in normal gaze, with limited motility in adduction and superior gaze. The two most common causes of an acquired third nerve palsy are microvascular ischemic and compressive. Microvascular ischemia is usually seen in the setting of diabetes or hypertension and is generally self-limited. Compressive third nerve palsy is most commonly due to a posterior communicating artery aneurysm. Meningitis and inflammation can also cause a third nerve palsy. This animation demonstrates a right third cranial nerve palsy. Notice the ptosis and downward and lateral deviation of the eye with a large pupil. As the patient follows the target, they cannot adduct the eye or fully elevate the eye. The fourth cranial nerve. The nucleus is located at the periaqueductal gray matter of the midbrain. It innervates the contralateral superior oblique muscle. A lesion in the fourth nerve produces vertical diplopia, limited motility in excyclotorsion, and may produce hypertropia, defined as a pupil that is positioned higher compared to the normal eye. Patients often adopt a characteristic head tilt away from the side affected to reduce their diplopia. Fourth nerve palsy may be congenital or acquired. Acquired fourth nerve palsies are more common and can be associated with trauma, hemorrhage, microvascular ischemic, demyelinating disorders, tumor, or can be iatrogenic. Bilateral fourth cranial nerve palsies are rare, but a compressive etiology should be considered. In congenital cases, approximately 1/3 to 2/3 of young children presenting with the fourth nerve palsy will actually present for evaluation of a head tilt. This animation demonstrates a cranial nerve 4 palsy. Notice the hypertropia of the right eye during adduction. As the patient follows the target, the right eye drifts upward as it turns inward. The sixth cranial nerve. The nucleus is located at the floor of the pons. It contains two sets of neurons. One set of neurons forms the medial longitudinal fasciculus, or MLF, that projects to the contralateral medial rectus subnucleus within the midbrain. The second set of neurons forms the fascicular and peripheral sixth nerve, innervating the lateral rectus muscle. A nuclear cranial nerve 6 lesion results in an ipsilateral horizontal gaze palsy, such that the eye on the same side of the lesion cannot abduct, and the eye opposite to the side of the lesion cannot adduct. A paramedian pontine reticular formation, or PPRF, lesion, which is in the pons, can result in a horizontal gaze palsy in the direction of the side of the lesion. A peripheral cranial nerve 6 lesion produces limited abduction on the same side of the lesion. All of these variations can result in binocular horizontal diplopia. Congenital sixth nerve palsy, also called Duane syndrome, is a congenital absence of the cranial nerve 6, and interestingly, patients often do not complain of double vision or diplopia. Acquired sixth nerve palsy can be associated with multiple etiologies that tend to be age-specific. For example, post-viral is seen more commonly in young patients, generally less than 15. Neoplasm is more common in younger than older patients. Ischemic mononeuropathy is seen in older patients, generally greater than 55, with diabetes and hypertension, and is also self-limited. Demyelination, for example, multiple sclerosis, is seen in younger patients, generally less than 45. An acquired sixth nerve palsy can also be seen with elevated intracranial pressure, for example, with pseudotumor cerebri. This animation demonstrates a cranial nerve 6 palsy. Notice the limitation of abduction of the right eye, but normal motility in adduction as it follows the target. Internuclear Ophthalmoplegia, or INO, is a type of gaze abnormality characterized by abnormal horizontal eye movement with poor adduction of the affected eye and corresponding abducting nystagmus of the contralateral eye. patients may experience horizontal diplopia. INO localizes to a lesion in the medial longitudinal fasciculus in the dorsomedial brainstem on the same side as the eye that has limited adduction. Lesions resulting in vertical gaze palsies can be classified as nuclear or supranuclear. In contrast to a nuclear lesion, the vertical gaze palsy seen in a supranuclear lesion, such as dorsal midbrain syndrome, can be overcome with a Bell's maneuver, which is when the eyes are closed tightly, the eyes reflexively move upward, or a doll's eye maneuver. Specifically, patients will demonstrate absent voluntary upward gaze. However, Bell's or doll's eye maneuvers are still able to elicit a reflexive upward movement of the eyes if the lesion is supranuclear. In addition to ptosis, myasthenia gravis can also present with disturbances in ocular motility, although symptoms can be intermittent and fluctuate. A hallmark of myasthenia gravis is that symptoms are worsened with fatigue and improve with rest, and a common exam finding is eye fatigue with prolonged upgaze. Up to 90% of patients with myasthenia gravis have ocular manifestations, and at the time of diagnosis, approximately 3/4 of patients have ocular symptoms. In up to 50% of patients, their initial presenting symptoms leading to diagnosis of myasthenia gravis are ocular. 50 to 80% of patients with ocular myasthenia gravis will progress to generalized myasthenia gravis within a 2 to 3 year period of time, and remission occurs in 10 to 20% of patients with ocular myasthenia gravis. This video demonstrates a patient with nystagmus. Nystagmus is a rhythmic, involuntary oscillation of the eye or eyes in which the abnormality results in a slow drift from fixation followed by a corrective saccade. There are two main categories of nystagmus, jerk and pendular. By convention, the direction of jerk nystagmus is defined by the fast movement of the eye. Pendular nystagmus refers to an abnormal movement of the eyes without a fast phase. In other words, the movement of the eyes is the same speed in either direction. Most types of nystagmus are non-localizing. However, there are a few that do localize. For example, downbeat nystagmus localizes to the cervicomedullary junction. Seesaw nystagmus localizes to the paracellar region. Periodic alternating nystagmus localizes to the cerebellum, and upbeat nystagmus can be associated with the brainstem lesion. Next, our focus will shift to the posterior ocular exam. The red reflex is a reddish-orange reflection from the retina when using an ophthalmoscope and is your first basic step in beginning the posterior exam. Presence of a red reflex suggests that there is no gross media opacity, such as cataract, vitreous hemorrhage, or vitreous opacity, or obvious posterior retinal pathology such as mass or retinal detachment, interrupting the normal retinal structures of the posterior pole. Absence of red reflex is an abnormal exam finding. This is an image of the optic nerve. Remember, when locating the optic nerve with direct ophthalmoscopy, first look for the red reflex and continue to follow in closer to the patient until the retina can be viewed. This may require you to get very close to the patient. Remember to use your right eye when examining the patient's right eye and your left eye when you are examining the patient's left eye. Locate a vessel and track the vessel as it increases in caliber, which will lead you towards the optic nerve. When examining the optic nerve, you should pay attention to certain basic characteristics. First, it is useful to estimate the cup-to-disc ratio. Here, the central cup diameter and the total disc diameter are labeled. The cup-to-disc ratio is generally represented by a decimal number between 0 and 1, such that 0.1 would suggest a very small cup and 0.9 would represent a very large, nearly totally cupped nerve. The average normal cup to disc in the population is approximately 0.3. In addition to cup to disc ratio, other important clinical exam features of the optic nerve include presence of optic nerve edema or optic nerve pallor. It is helpful to compare the symmetry of a patient's optic nerves with respect to all of the above characteristics. The retinal vessels can provide clues to the status of the patient's medical conditions. Here we see normal retinal vessels with respect to caliber and perfusion. However, presence of abnormal vessel attenuation or sclerosis is often observed in patients with hypertension and hyperlipidemia. AV nicking, enlarged veins, or small intraretinal hemorrhages are commonly observed in poorly controlled diabetics. On the left is a photo of a normal optic nerve, serving as comparison for the two images on the right, illustrating edematous optic nerves. The images on the right demonstrate margins of the nerves which are blurred. See the black arrows. And the vessels are obscured and congested. See the green arrows. The lower image also demonstrates multiple peripapillary flame hemorrhages. See the white arrows. Remember, when the term papilledema is used, it refers to optic nerve edema in the setting of documented elevated intracranial pressure. Usually, intracranial pressure is elevated at greater than 25 centimeters of water in these patients. Optic nerve head edema may occur in the presence or absence of papilledema. Papilledema is defined as optic nerve edema in the setting of elevated intracranial pressure. Therefore, a diagnosis of papilledema cannot be made without knowing the intracranial pressure. The differential diagnosis for optic nerve edema with or without papilledema includes meningitis or other CNS infection, presence of intracranial mass, malignant hypertension, toxicity from certain medications such as vitamin A derivatives, ethambutol, linazolid, or tetracyclines, optic neuritis, for which less than 50% of patients will actually have optic nerve swelling on exam. Symptoms of optic neuritis include unilateral subacute loss of vision, decreased color vision, and is generally associated with retrobulbar pain that worsens with ocular movements. Ischemic optic neuropathy has two main categories, arteritic and non-arteritic. Exam findings of ischemic optic neuropathy typically demonstrate optic nerve edema. Symptoms are generally painless acute loss of vision, often with specific visual field defects. Arteritic ischemic optic neuropathy can be associated with giant cell arteritis and may have constitutional symptoms. It affects patients greater than 55 years old and affects more women than men at a ratio of 2:1. Studies reveal an elevated ESR and an elevated CRP. It is important to start steroids if you have high suspicion, given risk particularly of vision loss. Temporal artery biopsy is used to confirm diagnosis and should be performed within 1 to 2 weeks of starting steroids to not compromise the result of the biopsy. Non-arteritic ischemic optic neuropathy is generally thought to be an idiopathic ischemia of the posterior ciliary artery. Risk factors include hypertension, diabetes, sickle cell disease, transient hypotension, for example, during surgery, and is associated with age greater than 55, having a crowded optic nerve, meaning a very small cup-to-disc ratio. There is no standard intervention, and patients may have partial recovery over time. One of the more common causes of optic nerve head edema that occurs only with elevated intracranial pressure or papilledema is idiopathic intracranial hypertension. This is typically seen in young obese females of reproductive age. Findings include optic nerve swelling and elevated intracranial pressure confirmed by lumbar puncture with otherwise normal CSF studies and normal CT and MRI. Symptoms include transient vision loss, diplopia, and pulsatile tinnitus. Intracranial vascular abnormalities, such as venous sinus thrombosis, should also be included in the differential for papilledema. Symptoms include headache, blurred vision, seizures, or other focal neurologic symptoms. Any patient imaged for evaluation of possible papilledema should have a CT scan of the brain with intracranial CT venogram or MRI of the brain with intracranial MR venogram to rule out venous sinus thrombosis. This table compares optic neuritis, arteritic ischemic optic neuropathy and non-arteritic ischemic optic neuropathy. In general, optic neuritis affects patients less than 50 years of age compared to AION and NAION. The ratio of females to males is approximately 2 to 1 for optic neuritis and AION compared to approximately equivalent for NAION. Vision loss tends to occur over hours to days in optic neuritis, and in both AION and NAION, onset of vision loss is sudden and tends to have a lesser effect on color vision. Appearance of the optic nerve may provide clues to the diagnosis, with least notable optic nerve abnormalities seen in the setting of optic neuritis, specifically a relatively normal appearing optic nerve or mild optic nerve head swelling is seen in less than 50% of patients. Visual field defects are diffuse in optic neuritis as opposed to specific altitudinal defects correlating to the area of affected optic nerve seen in AION and NAION. Optic neuritis patients also have the best visual prognosis. Diagnosis is determined by presence of optic nerve enhancement in optic neuritis. Patients with AION will have an elevated ESR and an elevated CRP, and definitive diagnosis is made with a positive temporal artery biopsy. NAION is a diagnosis of exclusion. Central retinal artery occlusion usually causes sudden, severe, and painless vision loss. Patients may have a history of temporary transient vision loss, also termed amaurosis fugax. This is usually caused by occlusion of the central retinal artery, and the major risk factors include hypertension, diabetes, and coronary artery disease. On exam, the retina has significant pallor, often with a cherry red macula. Systemic evaluation requires cardiac and carotid workup. Central retinal vein occlusion can cause sudden or gradual vision loss, or may be relatively asymptomatic. On exam, this typically is described as a blood and thunder appearance, with diffuse venous dilation and tortuosity, and often diffuse retinal hemorrhages. Major risk factors include high blood pressure, cardiovascular disease, diabetes, and clotting disorders. Complications can include macular ischemia or edema, as well as vitreous hemorrhage and secondary glaucoma.